Okay, this training will be covering EKG review for ACLS, and this training can be used for the ACLS update or the review or renewal course, or it could also be used for the initial or new provider course as well. My name is Rob Watts. I'm an American Heart Association instructor. I'm a national registered paramedic with experience working on ground ambulance for about 20 years, and I also have experience as a flight medic as well. All right, let's get into it. So one of the things we're going to cover is when the heart is beating, so one of the first things we're going to look at is when we're looking at an EKG, we're looking at the heart actually beating and pumping blood around the body. P is the P wave, which is equal to the SA node up at the upper left. The Q is equal to when the electricity passes through the AV gateway. R is the ventricles, and T is the resetting. So let's go through this kind of slow. So your SA node, or your sinoatrial node, is your intrinsic internal pacemaker. When the cardiac cells fire, they, just like the conduction system in your, or the wiring in your house, the heart has its own conduction system. So the P wave is indicative of your natural pacemaker, or the SA node, from right there inside the heart. As electricity goes through the top of the atrium, we call this the PR segment. And when the atrial of the heart squeezes, blood is being squished down into the ventricles. The electricity continues through the AV gateway, the bundle of His, and then eventually the Purkinje fibers, which then fire the ventricle or squish the ventricles, which is represented on the paper as the R wave. This whole section here in green is called the QRS complex, and this is when your blood is being perfused throughout the whole body. This QRS section needs to be nice and narrow in your common normal EKG. As the ventricles start to relax, this segment here is called the ST segment. The QRS complex is your ventricle. As the ventricles start to relax, this is representative in the ST segment here. Your ST segment should be nice, normal, and flat, what we like to call the isoelectric line. If it's raised or lowered, that can be indicative of a heart attack. This segment here is called the QT interval. And each of these segments should be timed, and on the EKG paper will have time what's normal or what's off or wrong. For example, if your T wave was too high, that can be indicative of an electrolyte imbalance, such as high potassium, which can be deadly if it's too much. Here we can break down the EKG paper and what it looks like inside the heart. This originates from the SA node. This is represented on the paper as the P wave. The electricity, just like throwing a rock into a pond, the waves propagate outwards throughout the top of the atrium, which is the top of the heart. As representative on the EKG at the Q wave, this is when the electricity will go through the AV gateway, which is a gateway that goes from the top of the heart to the bottom of the heart. When the electricity will pass here through the bundle of His, and then the Purkinje fibers at the bottom, and again that's representative as the R wave. The whole thing resets, and this is your repolarization, or the resetting of your heart. On the right-hand side here, you'll see normal, fast, slow, and irregular heartbeat. Fast typically means a heart rate of above 100. Slow, when we're talking about bradycardia, that's typically anything below 60, and uh, a normal healthy adult. And down on the bottom right-hand corner, you have an irregular heartbeat. Now, this is just a drawing, so this isn't a real EKG there. But the reason why we're calling this an irregular heartbeat is what we're looking at is the distance between all these R waves. If you were to measure them out, they're actually all in different size. So in other words, your heart is beating irregularly. And you can see this on your patient as you walk up and you grab the wrist and you can feel an irregular heartbeat. Now, this could be normal for the patient, so you simply ask them, is this average or normal for you? So to start off, we're going to look at EKG rhythm here, and there's a bunch of different ways you can break this down. These are just my 5 steps that I came up that work pretty good. I ask myself, is it slow, fast, or regular? And this looks like this is a 6-second strip, so you can count your R waves, and this is about a 70 or 80, since there's 8 R waves, 7 R waves. This is about a 70 to 80 rate. Is it slow, fast, or regular? Is there a P wave present? So in other words, is the EKG or the electricity in the heart coming from the SA node? And is it up against the QRS? And here it certainly is. Is it regular or irregular? Again, meaning your R waves. Are they all marching out on time in a monomorphic morphology? In other words, are we looking at the distances here between the R waves and they all appear to be the same distance? Is it narrow or wide? Again, we're looking at the QRS complex here. This is nice and tight, not wide. And is anything missing? So in this rhythm, we're going to go ahead and call this sinus rhythm. We used to call these normal sinus rhythm, but we prefer the name sinus rhythm because everybody can have a different style EKG. So by definition, this should be 60 to 100 beats a minute in your normal, average, healthy adult. And is there a P wave present? Yes. And this would be your sinus rhythm. All right, next. ACLS or PALS is just a choice pathway. You walk in, you see your patient, they present to you, and you're going to make a choice of how you're going to treat the patient. So for ACLS, I want you to think about these 3 concepts, and this will help you through all of ACLS and your skill scenarios and when taking the test. And that is, if the patient is stable and non-symptomatic, then we just monitor the patient. If the patient is stable and symptomatic, so in other words, chest pain, diaphoresis, that kind of thing, altered level of consciousness, then we just give medications. If the patient, however, is unstable and symptomatic, then we turn to electricity. And this can change. Maybe your patient is stable and symptomatic when you arrive on scene or walk up and become bedside with the patient. And if while you're treating or you're doing your initial evaluation, the patient becomes unstable, in other words, really terrible vitals, extremely symptomatic, and then we go ahead and turn to electricity. So for our next rhythm here, we're going to count it up, and it looks like there's 4 R waves. So if this was a 6-second strip, this would be a rate of 40. So we're going to ask ourselves, is it slow, fast, or regular? And it looks slow. P wave present, yes. Up against the QRS, yes. Regular, yes. Narrow. Anything missing, no. So we're going to go ahead and just call this sinus bradycardia. Now, again, taking our breakdown of ACLS with this patient. If this patient was stable and unsymptomatic and there's nothing to do, we're going to call for contact a higher level of care. If this patient was stable and symptomatic, we're going to give a medication. And if they're unstable and symptomatic, we're going to go for electricity. So for our medications, we're going to use atropine. Now this comes typically in ER code carts or the paramedic drug box. You can find these 2 common packaging, and one thing to note about the dose that we're going to give to atropine is 1 milligram for each patient. This works by blocking your cranial nerve number 10, which is your vagus nerve. It's going to block that action in hopes that the heart rate comes up. So, but I want you to look at the packaging here and realize that this may be a 1 milligram what we call the pre-filled syringe. However, if it comes in the vial this way, pay attention to how much per milliliters this is packaged in. Most of the time in ACLS, they tend to package the medication in a nice, easy format because these are typical emergencies. They want you to pull up the drug and push it really quickly. We don't want to be messing around trying to figure out doses. But this is just something to keep an eye on. If the place where you're working just happens to have this packaging, it's at 0.4. So you're going to end up giving a little bit more than 2 milliliters to equal 1 milligram. So just keep that in mind. So in case your patient becomes or initially was unstable and symptomatic, we're going to give transcutaneous pacing. So we're going to place the pads on the patient, and if there's time, we're going to give some sedation. So my advice is always to give maybe 1 to 2 milligrams of Ativan to the patient. We're going to turn the pacemaker on, and as soon as we turn the pacemaker on, we're going to set the rate to about 60 or 70, and we are going to take over the drive, that SA node, from the patient's heart, and we're going to make the patient's heart beat at about 60 to 70, depending on the rate that we set. And we're going to get what's called capture, and we're going to make the patient's heart beat faster because it's beating at 30 or 40, and they're symptomatic because they've got such a low heart rate. Now, again, of course, if the patient was asymptomatic, then of course we're not going to engage pacing unless absolutely needed. And this is your new 2020 adult bradycardia algorithm. Other medications you can try if the patient remains after we give the atropine. And again, we're giving the atropine because we're hoping it blocks the action of your vagus nerves. Remember, if you stimulate your vagus nerve, your heart rate will drop and go down. So we're going to give the atropine, we're going to give 1 milligram, and if that doesn't work, we're going to try again in 3 to 5 minutes. And if that doesn't work, probably need to move on to something else. We can also consider dopamine at 5 to 20 micrograms per kilogram per minute to try to raise our heart rate up. But probably a better choice for me would be the epinephrine infusion, 2 to 10 mics per minute. And we're going to titrate and try to raise their heart rate. Remember, your dopamine is dose dependent. You can make it work on your kidneys, your vascular system, or your heart, depending on the dose you give. And the epinephrine can work on your chronotropic or your inotropic support with your heart, which usually in an emergency situation, usually epinephrine is probably the better one to choose. Now with this rate, again, we're going to look at it. Is it slow, fast, or regular? Tends to be a little fast here. It looks like it's about a rate of about 120. P wave present, yes. Is it up against a QRS? Yes. Regular, narrow, and nothing seems to be missing. So we're just going to call this sinus tachycardia. So again, when we say sinus, or when somebody tells you the patient is in a sinus rhythm of some type, again, that means we can see a P wave, and that tells us a lot about the heart or the pathology of what's going on with this patient. At least electricity is coming from the SA node, which is a good thing. So again, by definition, this is anything more than 100 beats a minute, but less than 150. Okay, here we have a rate of about 170 to 180, super fast. P wave present, it might be there, but it looks like it's buried because the rate is so fast. It's regular, it's narrow, so we're going to call this SVT. So this is supraventricular tachycardia. So think of when the electricity is going through the heart, it's jumping in a loop and making extra heartbeats. Kind of think of it that way. So this is part of the ventricles beating about a double speed of what it should be. So The problem with this is in the beginning, the patient's going to feel palpitations, which means they can feel their heart beating in their chest. And at first, they probably won't be too symptomatic. But the problem with this is eventually this is going to start causing pain and discomfort, abdominal pain, back pain, diaphoresis. They're not going to be very comfortable because you just can't live at a rate of more than 150 sustained. Now, if you got on scene and your patient was just working out or running around the track and they're beating at 170 beats a minute, that's not SVT, that's still sinus tachycardia. When we're talking about ACLS, we're talking about somebody who remains sitting in a chair, sitting down in a nice calm environment, yet they still maintain a rate of above 150. And they don't, the hallmark is they don't tend to drop. They're not trending your vitals, which is why you should take multiple vitals. If they're just staying at 170 and that's exactly where they're staying, that is SVT. So that's the difference between sinus tachycardia and SVT. So with this patient, if they were symptomatic and stable, we give medication, and the medication we give is adenosine. So this is a couple common packaging. Usually they come in 6 milligram for 2 milliliters. This is a fast push. Usually it's a 2-man job. We're going to hook it up to an IV as close to the heart as possible and quickly give a flush after you give this medication. It's got a half-life of about a second, so you need it to get from the vein over to the heart as fast as possible. The other packaging could be in the 12 milligram format. All depends on wherever you work and what you get. So our doses are, for the first dose is 6 milligrams. The second and third doses are 12. So again, you're going to try it and see if you can break this cycle. This medication works by blocking the AV node. Remember that gateway in the middle of the heart? It blocks that temporarily for a few seconds in hopes that the heart resets. Again, the first step though, you're going to try your vagal maneuvers. Again, your dose is 6 milligram. Your second dose is 12 milligrams, and your third would be 12. If the patient, however, became or initially was symptomatic and unstable on scene with a rate of above 150, we're going to perform synchronized cardioversion. So we're going to, again, put the pads on the patient. Your dose is 50 to 100 joules, and you're going to make sure that sync button is turned on. Each time you shock, depending on the manufacturer and how the software inside the machine is. Typically when you sync once, sometimes in some of the devices, the sync will turn off automatically. So you'll need to turn it back on. It all depends on whichever manufacturer you're using, but you want to make sure the sync button is turned on. On the EKG, you'll see little hearts or arrows synced with all the R waves, showing you that when this electricity snaps down, it's going to snap down right on top of the R wave. If you were to not turn on the sync button and you were to perform unsynchronized cardioversion, also called defibrillation, on a patient in SVT, you could send them in a VFib and kill them. So make sure your sync button is turned on. So here we see a ventricle tachycardia. So this is wide. The rate is above 150. This is no atrial involvement, so you're just looking at the ventricles, the bottom part of the heart. It's flopping back and forth. Now, the interesting part about this rhythm is you're going to ask yourself when you approach your patient, you're going to find out really quick if this patient has a pulse or no pulse. That's certainly going to change your care quite a great deal if the patient is up and sitting and talking to you, complaining of chest pain or whatever, versus lying on the floor in pulseless VTAC. So for starters, let's talk about a patient sitting upright who is stable, symptomatic, and sitting in VTAC. So we're going to go ahead and try adenosine or consult expert. That's the ACLS recommendation. If this patient was symptomatic and unstable, however, again, we're going to go back to our synchronized cardioversion. For VTAC, however, the dosing will be at 100 joules. So if this patient had no pulse, so what would be your guess, your initial treatment option? So if you had multiple providers, somebody could start CPR while someone else was setting up the defibrillator. However, if you were alone with this patient and they were in pulseless ventricle tachycardia, your first choice would be to defibrillate. So you're going to slap some pads on and defibrillate. Follow your device's manufacturer as far as how much power you're going to give. But the typical recommendation for most defibrillators is 120 to 200, or with the exception of the LifePak 15 from Physio Control. And their recommendation is to start at 200 and then work your way up 200, 300, 360. And this is your adult tachycardia rhythm for 2020. Your next rhythm here is VFib. So this is ventricle fibrillation. Again, this could have, or usually typically does not have, any atrial involvement. You're just looking at the ventricles, but they're fibrillating. They're quivering back and forth, and there's no mechanical pumping action going on. So your heart is quivering, electricity is firing all over the place, but there's no mechanical pump, squishing blood all around the heart, getting blood up to the brain and keeping this patient alive. So essentially this patient is dead. So are the medication or procedure, we are going to give defibrillation. So again, if you're alone. If you have multiple providers on scene and they enter ventricle fibrillation, it is okay to start CPR. However, do not delay defibrillation in any way. This is just like VTAC, pulseless VTAC, these two rhythms are shockable rhythms. You initially want to shock these rhythms with defibrillation. Your next rhythm here looks like a slower rhythm. However, the key note here is this patient has no pulse. So we call this PEA, or pulseless electrical activity. This rhythm could be any rhythm up here. This is just, I just picked a random slow rhythm to be up here, but any rhythm with no pulse is called PEA. And what procedure are you going to use with PEA? And that's CPR. Your next rhythm here is flatline, and we call this asystole. So again, this is not a shockable rhythm, so the only thing we can do is CPR. Unfortunately, on TV, they show shocking this rhythm. That's not true. Okay, so this is your adult cardiac arrest algorithm for 2020. Here's how you can easily break this down. So you have two sides here, one left and one right. On the left-hand side, you have ventricle fibrillation or pulseless VTAC. So these two rhythms is exactly what the AED would look for. So if you don't know what's going on with the patient's heart and the public or lay provider or healthcare provider places the AED on, analyzes, what the AED is going to charge up for only two rhythms, and that is VFib and pulseless VTAC. This is a good thing because this is a shockable rhythm, and so we've got a possibility of saving the patient. So as fast as possible, we're going to get that shock on board and start CPR for 2 minutes. Start IV access, and as soon as you can, we're going to give the dose, the drug we're going to give is epinephrine. So that's okay to go ahead and get that on board as fast as possible. And again, we're going to reanalyze. If they're still sitting in VFib or pulseless VTAC, we're going to shock again, 120 to 200 joules, and just keep repeating. Do 2 minutes of CPR, shock, epinephrine, and continue. After several rounds, or whenever you get a chance, if you're still not having any luck after defibrillation, and rounds of epinephrine and CPR and still no luck, you can go ahead and consider amiodarone or lidocaine. Amiodarone works by blocking all the channels in the heart, the sodium, potassium, and calcium, um, and makes the heart itself more susceptible to the defibrillation, the shock. Lidocaine works just as simple as you think it does. It just numbs the ventricles, again, in hopes to break the cycle and to try to get them back into a normal rhythm. On the right-hand side, not so much luck. So over here, we're going to get sweaty and do some work. On this side, it's just CPR and epinephrine, and that's it. So we're just hoping that we build up some sort of rhythm that we can shock, that we can work with. In a realistic sense, typically if people have entered PEA or asystole, they are dead. They're usually not going to get these patients back. Over here, there is a possibility in the beginning, but as every minute goes by, they say after 10 minutes of no oxygen to the brain or 10 minutes of working the patient, you typically don't get these patients back. So moving on to some other common rhythms we might see. This one here has a very chaotic and noisy baseline, almost fibrillating, yet we're seeing ventricle spikes here. So this is a nice way of looking at this rhythm and actually seeing the two different parts of the heart. This is your ventricle, and this isoelectric line, this imaginary line that runs down through the rhythm, is your atrium. So this would be pretty simply called atrial fibrillation. So the hallmarks to this is the ventricles don't all match up. They're very irregular. The atrial rate can be anywhere between 350 to 750 beats a minute. So just like when that electricity wave propagated outwards nicely and smoothly through the atrium, in this kind of patient, you're looking at a very chaotic rhythm where electricity is firing pacemakers all over the top of the heart, just very chaotically and randomly. And every now and then the electricity goes through the AV gateway and goes to the ventricles, and then that's how the ventricles fire. So this patient, if this is normal for this patient, that's okay. Some patients live just fine with this. Later in life, they could be on medications like amiodarone pills or diltiazem or cardizem pills to make sure these rates don't get out of control. So this could be very normal for the patient. Okay, here this rhythm is called, again, we have ventricles. They're a little wide. They're upside down. That's okay. It all depends on whatever lead you're looking at. But the atrium, the rhythms between the ventricles here, are seesaw pattern or sawtooth. So this is indicative of what we call a flutter. So the ventricles are firing pretty much on time, but the problem is the rate is really high and flopping back and forth for the atrium. And these patients generally usually tend to code after a few minutes of sitting in this, or they'll do runs of flutter, go back and forth between normal sinus rhythm, and eventually you're going to be looking at a code most likely. Okay, and here, so we're getting into some of our AV blocks. So this is, remember, in the middle of the heart, that's your AV gateway from the top of the heart, the atrium, down to the bottom of the ventricles. So when this becomes problematic or the electricity is not being let through, this is what we call our AV blocks. So on this one, the hallmark of this, everything looks normal except for is the P wave up against the QRS, and it is not. So as you see, the P wave here is a fair distance away from the Q wave. Each of these boxes is 0.04 of a second. So you're not talking about a very long time here, but it's very noticeable on the EKG. So we call this a first degree block. So your PRI is more than 0.2 of a second here in length, which is pretty long. What medication is contraindicated with AV blocks? We tend to find some slower rates with the AV blocks. So the first medicine that everybody reaches for would be your atropine, but that is wrong. So the medications contraindicated with AV blocks is atropine. Do not give it. So the next one here will be your second degree type 1. So how we differentiate this is everything looks pretty normal here. However, if you notice, your P wave here has gotten a little longer and away from your Q, and here even more so longer, and then eventually drop. So right here you should have a normal QRS complex. However, it's gone. It's been dropped. So this is called the Winky Bach. So the saying is longer, longer, longer drop. That's the Winky Bach. So this was second degree type 1. Treatment, there may not be much to do with this. Again, we're not going to give atropine, but if this patient becomes unstable or symptomatic, then we may need to pace them. They may need an internal pacemaker placed. So we need to consult expert cardiologist. Here's another version of the second degree type 1. So again, here's looking kind of normal. T wave. Here again, here it starts all over with your P wave, but it's a little long, even longer, and then again, we're missing a QRS. So the next one here is the second degree type 2. So the hallmark of this is the rhythm, all in all, looks pretty normal. However, you're just missing ventricles here. You've just simply got complete drops. This wouldn't be a problem. However, if the patient continues to have more and more dropped QRSs, that of course means a loss of perfusion. So the patient may eventually start to feel it. Hallmarks could be very dizzy or altered, chest pain, that kind of thing. And again, this patient most likely will, if they become pretty symptomatic and unstable, we'll have to put them on the pacemaker or put them on transcutaneous pacing until they can get to the ER. Here, the last one for the AV blocks here, it's actually, you can actually see the P waves are actually marked on this. And if you notice, the P waves are all marching out perfectly on time. The R waves are all marching out on time. They're upside down, that's okay. But they are a little wide. But the hallmark to this rhythm is the P waves are doing their own thing and the R waves are doing their own thing, but there is no correlation here whatsoever. These just seem to be all over the place. So we call this a third degree AV block. Typically when you see somebody in third degree AV block, be prepared that they could code at any minute. So unless they've been sitting in third degree block for a really long time, be pretty scared. Just get ready. So the treatment is we're eventually going to have to try to either pace this person or, again, most likely you're going to be looking at CPR. These patients typically are circling the drain. This is not congruent to a patient who's perfusing very well because this pump is broken and they're not going to last very long. Here again, you might see runs of this, and again, the patient might code on you. This is called, it looks just very similar to VTach, or ventricle tachycardia, which it is. It's a cousin, and we call this, instead of monomorphic VTach, this is called polymorphic VTach. And the hallmark to this is it tends to look like a twisted party ribbon. So it kind of goes up and then down and then back up again. Again, these patients are either going to be very close to coding, or you're going to find they're going to be running normal sinus, do runs of polyventricle tachycardia or torsades, and then go back into normal sinus. Again, these patients need to be very closely monitored. You could be looking at a code. So this one is indicative of somebody, workout supplements, caffeine or cocaine tend to do this rhythm, and it's called a PVC, or a premature ventricle contraction. This is, I call this a heart hiccup, because that's essentially what it is. Just like hiccup, we don't thoroughly understand exactly why we hiccup, and what typically can cause it. But this is kind of the same thing, where we understand what may cause or lead to you running with PVCs, like caffeine, very commonly. Uh, but at the same time, we don't truly understand all the nuances of why this happens or what's going on in the heart. It's just a heart hiccup. If there's only one every hour, no big deal, or one every now and then, not a big deal. As long as this doesn't interfere with perfusion, there's probably nothing to do, and just monitor the patient. It'll probably heal itself. Okay, so this rhythm is pulled directly from a 12 lead. So you're looking at leads 2 and 3 here. And the hallmark to this is, here's the P wave, the Q, the R. However, the ST segment here tends to be elevated. So here's your S point, there's your T, really high up there. So this segment needs to be on the baseline here. Remember your isoelectric line. So this is called ST elevation, or a STEMI. ST elevation MI. So this patient is having a heart attack. So we're going to treat them for a heart attack. So in this example, ACS, which is acute coronary syndrome, we're going to give oxygen only if the patient is less than 94% or short of breath. We're going to apply the monitor EKG SpO2 side stream end tidal if it's available. We're going to grab our vitals, our blood pressure, heart rate, respiration rate. As quickly as possible, we're going to give aspirin, 160 to 325. And if possible, if you can give your aspirin as soon as you notice this patient, that would be preferable. As you're getting your vitals, we want to get that aspirin on board as fast as possible as a platelet aggregate. It's going to allow those the platelets inside the blood to become very slick and slide past any blockage that's going on as a coronary blockage. As soon as you can, we're going to get our 12 lead, and we're going to trend out our 12 leads. So we're going to get multiple 12 leads to watch this patient very closely. We're going to start an IV, and only when you start a 12 lead and after the 12 lead has been completed and the IV has been established, can you then give nitroglycerin? Dose is going to be 0.4 milligrams, sublingual tablet or spray. And we're going to give that every 3 to 5 minutes as long as the patient has chest pain. Your endpoint goal is going to be 0 out of 10 chest pain. No chest pain is what we want. So after you've given about 3 doses of nitroglycerin, we can go ahead and give either fentanyl or morphine if the pain remains. So the reason why we do this, we don't give nitroglycerin right away as soon as we arrive to this patient, which is commonly done as a mistake. But we want to make sure we get a 12 lead because we're looking for your right-sided or inferior heart attack. We'll get into that in a moment. And we want to make sure an IV is established, again, for the same reason. In case you miss it on the 12 lead, they're having a right-sided or inferior heart attack, you want to make sure you have an IV established. So if you gave nitroglycerin to that patient, you could bottom the patient out, taking away and making nitroglycerin makes your vessels bigger. If we make your inferior or superior vena cavas bigger, we can end up making your tank bigger while bottoming out your patient's heart, meaning not that much blood now is going into the heart, and now they have no cardiac output, and you can send them into ventricular fibrillation or kill them. So we want to make sure that an IV is established before we start giving doses of nitroglycerin. So what does that look like? So let's look at leads 2, 3, and AVF. This is what you would call your inferior. There's a bunch of different names to this type of heart attack: right-sided heart attack, RV infarction, RVI. So we're looking here at leads 2, and we can see the elevation right there. Leads 3, we can see the elevation here, and AVF, we can see it here as well on the AVF. So here is in the color diagram to match the 12 lead here. So we call this the boot, or it looks like a shoe. It's the yellow portions here. So leads 2, 3, and AVF. So this is on the right side of your heart, on the back side. So in this case, we're going to withhold nitroglycerin. We can give nitroglycerin in the ICU or in the critical care area of life, but we're not going to be able to give, we should withhold heavy doses of 0.4 milligrams in the field pre-hospital. At least wait until they get to the hospital. They can start them on a tri-dil drip and titrate the nitroglycerin a little softer. Okay, thanks for watching.